So thank you so much for coming out tonight. I'm sure folks will be trickling in, but I just want to be mindful of everybody's time. My name is Monique Dawkins. I'm the Assistant Director of Education Programs at ACCC, and we're definitely happy to see you tonight. I'll just start off by just sharing a little bit about ACCC for those that may not know about our organization. So the Association of Community Cancer Centers, we are a membership organization where we really focus on education and advocacy for cancer centers that are in the community. So what we mean by that is that it's not just a community hospital, but our membership of 2,500 cancer centers really runs the gambit from an academic center such as like Duke or Moffitt in Tampa to, you know, a private practice or those mom and pop shops in the community, if you will. So I think that the strength of our organization is really the fact that we have a variety of types of members, and we're really grounded and focused on how-to strategies for the multidisciplinary care team. So we like to develop educational materials that are for physicians, of course, but then nurses and radiologists and administrators. We have a strong financial advocacy network. So we really run the gambit in terms of the type of programs that we develop, and we're constantly focused on various types of tumor specialties or pan-tumor projects. So I would advise everybody, if you have not done so, to go to our website, which everybody should have one of these brochures that I'll speak to in a moment, but it has our website on it. You'll be able to not only find out who and what sites are members of our organization, but then you'll also be able to find out a little bit more specifically about cutaneous squamous cell carcinoma. So this project is sponsored for us by Regeneron and Sanofi, and this is actually our second phase of this project. The first phase, we really did some kind of fundamental work, if you will, where we went out to a couple of our cancer center programs and really led focus groups to discuss what are people doing, what are best practices, what are pain points as they relate to trying to care for these patients and manage patients that have this disease state. So we put together this publication as a result of that. So please do feel free to check that out in front of you. We're also developing a comprehensive resource library that is still in the works, but it's going to be available on our website. That'll be like a one-stop shopping, if you will, for all of the various types of resources that are available right now through ACCC, but some that'll link back to some formal guidelines, clinical guidelines, and things like that in the space. So we're very excited tonight to have with us Dr. Desiree Ratner. She is a solo practitioner, and she can speak a little bit to that, but she's on faculty at NYU. And so we're definitely excited to hear a little bit more about not only squamous cell carcinoma, but how do you manage that? How do you identify it? What are the risks? What do we need to know? So thank you so much, Dr. Ratner. I'm going to turn it over to you.
Thank you.
Yes.
Very happy to be here. You all can hear me okay, right? I tend to have a softer voice. So I'm currently a solo practitioner. I was in academics for over 20 years at both Columbia and Mount Sinai. And so I started this venture about 1.5 years ago. My practice focuses only on skin cancer. So I have a substantial group of patients with advanced skin cancers or difficult skin cancers that tend to come my way. So I'm probably going to gross you out a little bit during dinner, for those of you who aren't physicians. So my apologies in advance. Before anything, I have to do disclosures. Let's see if I can make this work. Uh-oh.
Probably just have to type it one good time.
Okay, yeah, fabulous. Okay, so I'm on an advisory board and advisory council for Regeneron Sanofi, and on the speaker bureau for Genentech. All right, so you have to abide by the rules. So following this session, you should be able to do a lot of things. So you'll be able to identify lesions suspicious for SCC. You'll understand the clinical and histologic features of high-risk SCC, and you'll understand the management options for low-risk and high-risk SCC, including new treatment approaches for advanced disease. Welcome. You didn't miss anything yet. All right, so before you talk about SCC and what it looks like, you've got to know the epidemiology of it. And there are over 1 million new cases diagnosed every year in the US alone, and the annual increase is now around 2 to 4%. So that's a pretty big number. there's a significant rate of metastasis. And people don't normally think about SCC as metastasizing, which is part of the problem. You see these little things and you think, that's never going to metastasize. But the fact is there's about 4% risk of metastasis overall. And so part of what we're going to talk about is how do you predict who's going to have that problem and who's not? The case fatality rate is approximately 15,000 cases per year. So it's actually a big number, and it's about twice the rate of melanoma fatalities, which again, people don't normally think about. So to be very simplistic about it, you can classify SCC as either low risk or high risk. And of course, there's everything in between, but if you think about it in this way, this will help you to predict how these patients need to be thought about and how they need to be managed. So we're actually much better at managing SCC than these numbers would tell you. So these are really old numbers. They're from a study from about 20 years ago, but it's probably one of the better comprehensive studies done by Dan Rowe. But if you look at all of the tumors with all of the modalities, the 5-year recurrence rate with all of the literature up to about 20 years ago was 5 to 8%. So the recurrence rate 5 to 8%, metastasis rate about 5%. But we know, as people who treat this disease, that the numbers aren't nearly that high. So what you need to do is think about these as just a frame of reference. And so when I tell you that the numbers for a particular high-risk tumor are twice the rate or 3 times the rate, you can multiply and then you can scale back. But you at least know the ratio that I'm talking about. So 5-year recurrence 5 to 8, 5-year metastasis 5%. All right. Ooh. Okay. What happened? I went to sleep. Oh, I'm getting ahead of myself. Look at that. Okay, so low risk, medium risk, high risk. In fact, these are all high risk, but you see that they have varying degrees of risk. So this is a heart transplant patient. It's a relatively easy lesion on her cheek. She ended up dying of metastatic squamous cell carcinoma, not from this one, but from another one. So she's a high-risk patient. And this is a woman who actually had metastases from this lesion at the time that she presented to me, but no one knew that the metastases were from that, which is unclear to me. She'd already had a neck procedure and radiation to her neck, and I guess they weren't sure where the primary came from, but I knew. And this is the last one. Sorry to gross you out. I'll go to the next slide so you don't have to look at her. But that was a schizophrenic patient who came in with her aide, and her aide had been dressing that every day for several years, and finally thought that it was too difficult to do that, and she thought that she needed to come in. And at the time that she came in, there were no evidence of metastases. By the time she got to the next practitioner, she had axillary mets, and so you know where that went. Our goal as clinicians is not to have patients get to the point where either they're that big or that they have metastases. So we need to identify very early on who the problem patients are going to be, where the problem tumors are going to be. So what are the risk factors for skin cancer, for cutaneous SCC? Well, we're all familiar with ultraviolet radiation. That's the big one. But there's some other ones that people don't think about quite as much, and those include ionizing radiation, so X-ray treatment, genodermatoses, as I'll talk about in a little while, HPV, which is a good co-carcinogen, chemical carcinogens, immunosuppression, and then chronically injured or diseased skin. So this is a lady who's had a lot of UV exposure. So this is the classic type of person that you would expect to get a squamous cell carcinoma. She's had a lot of wrinkles, she's had a lot of sun, she's going to get a lot of skin cancers. But the fact is that here's a guy who doesn't have a lot of wrinkles. He has had a lot of sun because he has more skin cancers than she did. So part of this is a genetic predisposition to developing skin cancers, and UV radiation affects different people in different ways. So he's got a small lesion on his cheek. He's had a whole bunch of other stuff going on. So UV radiation is the #1 risk factor. Okay, ionizing radiation. You don't quite see as many patients with this as you used to. But in the 40s and 50s, there were a lot of people who got radiation for benign dermatoses. And before that, and to some degree after that, but really that was the peak. The risk of getting an SCC is directly related to the total accumulated dose. This is going to sleep periodically. Total accumulated dose of radiation. And there's a latent period before you actually get tumors, and it varies inversely with the total dose that you get. So if you get a relatively low dose, it's going to be a while before you get them. If you get a high dose, it's going to be a shorter interval. Tumor development is typically related to X-rays, but gamma rays and Ren's rays are also risk factors. So this is a lady that I saw about 20 years ago who had gotten radiation for her psoriasis on her scalp. It was really, really bad psoriasis. And you can see she's got a couple things on her head, and actually she had them all over her head and ended up needing to have her scalp removed because of the progressive skin cancers that she developed from radiation for psoriasis. And this is a lady who came in on Ellis Island, and they radiated her for tinea capitis. And after that, she wore a wig. So since age 3, she wore a wig, and she started developing skin cancers, which is really kind of fascinating. So she's no longer around. Genodermatoses, so albinism and xeroderma pigmentosum we're familiar with. Those are patients who get a lot of skin cancers. But dystrophic EB patients with a chronic blistering disease also die of squamous cell carcinoma. And people with epidermodysplasia verruciformis that I'm not really going to talk about have HPV in their tumors. So this is it's just a different group that has a genodermatosis with an issue. This is a patient with EB. They don't have a squamous cell carcinoma yet, but with chronic scarring dermatoses, this becomes a problem. HPV, I just mentioned, there are like 200 types of HPV, and so we talk about the low risk and high risk ones, but really there are only like 6 types that are normally tested for. 6 and 11 are common in genital tumors. 16 is common in periungual tumors, but really in any skin cancer, if you really looked hard enough for HPV, if you thought it was there, you would find it. You just need to be able to type it. So this was an HPV positive tumor. I think it was HPV3 or something. It was at a time when there was a special lab, a research lab that you could send tumors to, and they would HPV type them for you. But now that doesn't happen so much anymore. So that's HPV, and then this is HPV. So this is a verrucous carcinoma. Looks for all the world like a wart. It was treated like a wart for a very long time, and then finally someone thought to biopsy it. So we'll talk about that one a little bit later. Chemical agents are another risk factor. Arsenic is really the big one. It used to be that there were medicines called Fowler's solution and Asiatic pills that had arsenic in them, and people would take them, for headaches and asthma. You can also find arsenic in tainted wine and developing water, unprocessed well water in developing countries. And then people who work with metal ore, insecticides also are exposed to arsenic. Sort of interesting, people who have had a lot of arsenic get all these little keratoses on their palms and soles, and they can develop tumors really anywhere on exposed or non-exposed skin. And they also get circular areas of hypopigmentation on the trunk, which I'll show you here. This is a African-American lady who lived in the South and drank well water all her life. And, these are raindrops on a dusty road is what that's called. And she had a ton of squamous cells all over her. So the last risk group we're going to talk about, except for one, is immunosuppression. And we hear a lot about this now because there are all these people getting transplants. And organ transplant patients are at exceptionally high risk. So in non-immunosuppressed people, the basal cells outnumber the squamous cells, but in transplant patients, squamous cells outnumber the basal cells. The ratio is reversed. They're actually 65 times more likely to develop a squamous cell, which is sort of frightening. Lesions tend to start appearing 2 to 4 years after transplant, but again, it depends on the immunosuppressive regimen that they're on. So that determines how quickly it starts and how many tumors they make. The lesions do increase in number over time. They also become more aggressive than in normal hosts, so you don't want to fool around with these. And the tumors can be potentiated not only by immunosuppressive medications in transplant patients, but people who are immunosuppressed themselves because of leukemia or lymphoma essentially are like organ transplant patients in many cases. So they can become tumor farms as well. So this is a heart transplant patient who looks like he has 3 or 4 little actinic keratoses on his head. They were all part of one big squamous cell carcinoma underneath. So things that look relatively banal on a transplant patient cannot necessarily be ignored and often need to be biopsied. This is another heart transplant patient who had been treated for the actinic keratosis on his nose for a very long time, just repeatedly freezing it, and finally someone biopsied it, and it was a squamous cell. The last thing is injured or chronically diseased skin. I don't need to read the slide, but basically anything that causes ulceration and scarring for years and years and years can make squamous cell carcinoma. So this is a lady with DLE who has a little baby squamous cell in the corner of her eye. And this is a lady with tertiary yaws. I forget what country she was from, but she had this on her leg. It was attributed to tertiary yaws, I guess, for a long time, and it turned into a giant squamous cell carcinoma. So you've seen this whole spectrum now of tumors, and low risk versus high risk is very simplistic. But we're going to go back a little bit and we're going to talk about low risk for a minute, because here's a low risk tumor. So what I mean by low risk is that it's small, less than a centimeter, it's well defined, it's primary, and it's on the neck, trunk, or extremities. So that's like the classic definition of a low risk tumor. And so with these low risk tumors, you can do almost anything and you can cure them, because all you have to do is treat them completely, and it's not very difficult. So what can you do? You can scrape and burn them, you can excise them, you can freeze them, you can radiate them, you can do PDT, and in most cases, you get a very high cure rate. So if you look at the column on the right, because we really care about greater than 5-year follow-up, more than less than 5-year follow-up, you can see that with all the non-Mohs modalities together, the cumulative rate of recurrence is about 7% with all of the different options versus Mohs, which has a much lower recurrence rate, as we'll talk about in a minute. But it just gives you an idea that if you ED&C something and it's really low risk, you only have a 3.7% chance of recurrence. It's really fine, but you've just got to know the tumor that you can pick and treat in that way. I should go back for a minute and just mention that when I talk about low risk versus high risk, I mean at low risk for metastasis, at low risk for recurrence, versus at high risk for metastasis or recurrence. So it's a way of thinking about tumors. So here's a tumor, which if you look at it, if it were like half that size, you'd say low risk, right? Because it's well circumscribed, just like this ball. And it is low risk, in fact, because this is a keratoid canthoma. So those of us in dermatology see these a lot. These are sort of low-grade keratinocyte malignancies that are a type of squamous cell carcinoma. They're unusual in that they go away. So they grow very rapidly over a period of months. They grow, they look awful, and then in most cases they resolve. They just regress and go away. So we can make that go faster by injecting with methotrexate or 5-FU. Sometimes just the biopsy makes them go away. So it's really an interesting phenomenon, but it rarely progresses to invasive or metastatic disease. And the reason that a KA doesn't progress is that it looks like this. So this is a real KA. You can see it's superficial. It's way high up there. It's got this big keratin horn in it. And over time, what happens is the skin part of the tumor, the lower part there, sort of regresses and the thing falls off and goes away. But if it has an invasive component down below, then that's not going to go away. That's a real squamous cell carcinoma, and then we have to treat it as such. So if they have an invasive growth pattern on the deep margin, then it can be hard to distinguish what looks like a KA from an actual KA. And about 85% of the time you can tell the difference. But if you can't tell the difference, then you've got to treat it in a more aggressive manner than simple intralesional methotrexate injection, for example. So this is a guy who was treated for what was thought to be a KA. It was scraped and burned. He was, I think, in Alabama. And he came to me about 6 months later with this thing, which does not look like the thing I just showed you, right? He's got this pink sort of ulcerated thing. And if you look around it, there's a very ill-defined nodule, and that was actually all part of it. So it was really hard. This was fairly early on in my Mohs career, and so I took a first layer, and that's what that was. And the black in there is tumor necrosis. It's not cautery. So after I did my first stage and it was positive everywhere, then I sent him to ENT, and they did a bigger resection, and they did a parotidectomy, and they did lymph node dissection, and he got radiation, and he survived. And this was about probably 18 years ago now. But you know, the moral of the story is it's not always a KA just because the pathology report says it's a KA. So you have to take into account all different kinds of factors. Does it look like it? You know, if you treat it, does it come back immediately? So this is just to let you know that low risk tumors should really be low risk, and one should not confuse one with another. So the other low risk tumor is a verrucous carcinoma. And again, what I mean by low risk is that they rarely metastasize. So I showed you a picture before, I'll show it again. They may resemble large warts. You can freeze them innumerable times and they won't go away. You do the biopsy and then you find out what they are. If you excise them adequately, it generally results in a complete cure. There are reports of malignant transformation after radiation, so you don't radiate a verrucous carcinoma. So this is the guy I showed you before, and this is actually, he had 3 recurrences with me because I didn't know much about these at the time. So I did Mohs on him twice, and I got clear margins. But the problem with these HPV positive tumors is the HPV lives around the area besides in the area, so they keep reinfecting themselves. So he ended up with amputation for his verrucous carcinoma. So I learned a lot from him. This is a guy who also has a Verrucous Carcinoma. You know, immediately he's going to get an amputation because that tumor looks a lot worse than the other one. However, they both behave biologically the same way. Okay, so you're getting a sense now of the clinical profile of a true high-risk tumor. So size is usually greater than 2 centimeters. There's anatomic site profile, which is ear, lip, central face, and also others, as I'll show you in a minute. Rapid growth, so that can also happen with a KA, but rapid growth in a squamous cell carcinoma can also be bad. Recurrence, if it's recurrent, it becomes high risk automatically, which is how these low risk tumors somehow become high risk tumors because they recur. Immunosuppression makes people at higher risk, and then again, if they arise within a scar or radiated site, it's that chronically diseased skin, that's a high risk tumor. So histologically, these also make sense. If it's a deep tumor, if it goes below the deep dermis, that's also a bad sign. If they're poorly differentiated instead of well differentiated, if they have perineural invasion, as I'll talk about in a minute. Again, if they've recurred, that shouldn't be in there, but I guess I'm emphasizing it. So if a tumor is big, and big is a sort of arbitrary term, but if you look sort of globally, size greater than 2 centimeters is considered the cutoff. However, if you're looking at the face, for example, the cutoff can be less depending on the area that you're looking at. But going back to this paper I was telling you about, big tumors recur at twice the rate of lesions that are small. So roughly 15% of cases. And they metastasize at about 3 to 4 times the rate of smaller lesions. So, you know, big tumors need to be treated with respect and treated completely so that they don't come back and they have a higher risk of coming back and metastasizing than the small ones. The 5-year cure rate is 70% with standard treatments for this high-risk large SCC. So this isn't something that you want to just go ahead and scrape and burn or freeze. You want to think a little bit more about that. So sample tumor, this will not be frozen, this will not be scraped. She just walked in. This is someone now who would get one of the new medicines for squamous cell carcinoma rather than having a humongous surgery, but the point is that she's at high risk. All right, anatomic site. So rates of recurrence and metastasis range from about 10 to 25% for lip and ear. So those are the classic high-risk sites. But other high-risk sites include scalp, forehead, and temple. And actually, most of the patients that I've had metastasized have had tumors on the scalp, forehead, or temple. Eyelids, nose, and mucous membranes, dorsal hands, and then genitalia or perianal region. Forget about those. But those are also areas that are at higher risk for recurrence and metastasis. So this is an ear tumor, so classic high-risk location. This is a perianal tumor, so a non-classic high-risk location, but one that needs to be remembered. So as I mentioned, if tumors grow rapidly and they're squamous cell carcinomas rather than KAs, they can metastasize in up to 1/3 of cases. Again, those numbers are high because now we're much better at treating them, but just think of it as 3 times the rate of a non-rapidly growing tumor. And tumors, again, arising in injured or chronically diseased skin, the rate of metastasis approached 40% at one time. Now we're much better at it, but again, the rates are higher than you think. This is not a KA. This was thought to be a KA. This was a rapidly growing squamous cell carcinoma that arose at about 3 weeks. It had a very infiltrative growth pattern on histology when I ended up doing Mohs on it. So just because it looks like a KA and the top of it might act like a KA on histology, you sometimes have to be wary. So the last few clinical features that are high risk are immunosuppression. The risk of metastasis is about 50% higher. History of previous treatment, about 25% for more cutaneous lesions, and ear and lip are higher than that. And again, history of radiation puts everyone at higher risk. This is a lung transplant patient with an itsy bitsy thing on her nose. But you have to have respect for someone as a transplant patient with a small lesion. They need to be treated, in this case, with Mohs surgery. This is another heart transplant patient with an itsy bitsy thing on his eyelid, also an invasive squamous cell carcinoma. Again, for someone like this, even though it's very, very small, you're not going to scrape and burn it on the eyelid anyway, but it needs to be surgically resected. This is just looking at histology. So well-differentiated tumors have a much higher cure rate of about 94% than poorly differentiated tumors. And you can see there the local recurrence rate and the metastatic rate. And again, we're just thinking about this in terms of multiples. These may not be the real numbers anymore. Maybe it's a 98% cure rate for well differentiated and 70% cure rate for poorly differentiated. It doesn't really matter, just to give you a sense of the spectrum. If they're deep, that's bad. So the local recurrence rate again is relatively high at about 17%, with a metastatic rate of about 45% when they're deep. So we have to have respect for those. This is a poorly differentiated tumor. This was frozen because it was thought to be an actinic keratosis before it was biopsied. And if something doesn't respond to freezing, then as dermatologists, we biopsy it because we want to make sure of what we're actually dealing with. So this is a poorly differentiated tumor, and it looks like nothing. Perineural invasion is the last high-risk feature. It only occurs in about 5% of tumors, and it refers to a tumor that hits a nerve fiber and then grows along it. It's called neurotrophic spread. It isn't clinically or histologically apparent sometimes until significant tumor extension has occurred. Oftentimes, as a Mohs surgeon, we see it sort of incidentally in our sections. It's called incidental perineural invasion. That's not as bad necessarily as clinical perineural invasion, but you can see that the local recurrence and metastatic rates, before we knew a whole lot about this, were about 47% both. And most patients with clinical perineural invasion or radiologic perineural invasion used to die within 5 years of presentation. Now we're, again, better at managing this group of patients. This is a tumor from a patient on the temple, sort of temple scalp area that had been resected by Mohs a couple of times, and then I got to see him. And you're not seeing his clinical pictures because they're gross, but this is his nerve, which is totally sucked in. That was his facial nerve. So let's talk about treatment for a minute of high-risk tumors. And the list of things that you can do, in my mind, is very short. Basically, high-risk tumors need to be treated surgically. And the best way of doing that is Mohs micrographic surgery, which basically allows us to look at all of the edges and all of the undersurface of the specimen to make certain that the tumor is all out. And I'll show you a picture of that in a minute. If you happen to be in a place where there isn't a Mohs surgeon, you can do just a wide incision with wider margins to an appropriate depth. And if you're lucky, you'll have someone who can give you complete peripheral and deep margin control, a pathologist who will be willing to do that. For very high-risk lesions now, we consider adjunctive treatment, such as radiation. But most of the time, you don't need that. So here is a schematic of a tumor. And skin cancers are like trees with roots. So you see the trunk, but you don't see the roots that are down there. So when a Mohs surgeon is taking out a skin cancer like this, what we do is we take it out, and you can see the roots still left down there. And what we do is we take this disc and we flatten it so that we can see all of the edges and all the undersurface of it. So we have technicians who process the tissue to enable us to look at the tumors in this way. So I can see that there's a little root going that way and a little root going that way, and then I can go back and take tissue only from where I need to take it. So I don't need to go all the way around and all the way under again. And the difference between this type of processing and regular processing of an excision, for example, is that excision specimens are bread loaf. The way you can think of that is, here's our loaf of bread, and it's sliced. But imagine that you have two slices and a root going that way in between the slices. You're not going to see it unless you have someone who's looking this way. So that's why the cure rates for excision are lower than most micrographic surgery cure rates. So I'm just going to show you a case or two so you understand how this works. So this is a renal transplant patient with a squamous cell carcinoma by her eye. This is a relatively small one. So here's her defect after a couple stages of Mohs surgery. And then the beautiful thing is we can repair it immediately. So we just repair her right in the office under local anesthesia, and then they look like human beings when they're done. So the goal is for the cosmetic outcome to be as nice as the oncologic outcome. So in general, despite all these horrible things that I'm showing you, primary cutaneous SCCs have a great prognosis. The Mohs surgery cure rates are 95 to 97%. So that's pretty darn good. People who get metastatic disease don't have a good prognosis. And things are getting better now, but at the time that I made this slide, the 10-year survival rate was less than 20% for regional notes, and less than 10% for people with distant metastases. So I'm going to tell you some better numbers now, so we'll have a happy ending. But the fact is that you want to diagnose these and treat these with the highest possible cure rate so that you don't have to worry about any of the ugly stuff. So now I'll show you some more ugly things. So this is a guy who had a squamous cell rise relatively quickly. You see there under his ear. And it wasn't there for very long, maybe a couple of months, he said. So I did Mohs on it, and that's his defect. And so I wasn't really happy with this, and I'll show you the closure in a minute, but I took him to the multidisciplinary tumor conference. So I closed him, I showed him the hole, and I said, you know, I really think that he needs something beyond my surgery because I'm not quite comfortable with this. And this was about 8 years ago, 10 years ago. And the group's consensus was that we should just watch him because my margins were clear and, you know, it looked really good. And it wasn't really that big. His defect was like, I don't know, 2.3 centimeters, but it did go to parotid. Nobody really cared. So here he is showing up in my office with his lymph node and his paralyzed facial nerve, and ultimately died of his disease. And this was before the era of all the magical things that we can do now, but our goal is to prevent this from happening. So there's a staging system that I have to tell you about because this is predictive, and it's helping us to figure out who needs to be treated more aggressively, who needs to be looked at more frequently than the run-of-the-mill patient. And so there's a group at Brigham and Women's Hospital, so BWH, and they looked at however many hundreds and hundreds of tumors and looked at the outcomes. They looked at who recurred, who metastasized, what happened, and they found that 4 risk factors in particular predicted poor outcomes. So I've been telling you about all the things that could be bad, but these are the things which together make it really bad. So poorly differentiated histology, tumor with a diameter of 2 centimeters or greater, perineural invasion of any caliber, and invasion beyond the fat, excluding bone. So I'm not going to talk to you about the AJCC staging systems because they're much more complicated. This is really simple and really easy. So if you have no risk factors, it's in situ, we don't have to worry about you. If you have one of those 4, your risk of a poor outcome is 1.8%. So if you have a patient with one thing and you treat them completely and effectively, you should be done with that. I'm sorry, 0 risk factors, T1 tumors. 1 risk factor is T2A, 9.9%. So you've still got to have respect for them, but if you manage them properly, they'll be fine. It's the T2B group that's scary. So they have 2 to 3 risk factors. A third of them roughly have poor outcomes. And that's really the group that we need to focus on because they're the ones that we can help. And my guy, if you think about it, he was down to parotid. So that was number 1 here. Let's go back. So it was down to parotid, and he had a diameter of 2 centimeters or greater. So it was really only 2 risk factors. It wasn't poorly differentiated. There wasn't perineural invasion that I saw. Ultimately, his facial nerve was paralyzed, so we know it had it somewhere. But that was the group that we should have been able to say, okay, he really does need adjunctive radiation or something else. And if there are 4 risk factors or bone invasion, everybody's going to do badly. So the T2B and 3 patients are the really high risk cSCC patients, and we know that they're going to have a greater propensity for invasion, recurrence, metastasis. We can't just scrape and burn them or do a little narrow excision with those. You need not only more aggressive surgical management, but also adjunctive treatment to avoid the high rates of morbidity and mortality that can ensue. So this is where the multidisciplinary management comes in, because the drugs that are out there now, I can't necessarily give, and I certainly don't give radiation. So patients with these aggressive tumors need dermatologists, surgical oncologists, medical oncologists, derm path people, transplant docs, radiation docs, ENT, plastics, oculoplastics. Really, this is a situation where everybody has to work together to manage these people. And I may be the point person because I'm doing Mohs on them and I'm seeing the perineural invasion and I know it's down to parotid and I know the location. So I will send them to my colleagues and say, you know, they're seeing you for consult. This is why I know that you're going to send them to the next person and the next person and manage them appropriately. Let's go back for a sec. This is another guy from the era before the modern era. So he's probably from about 10 years ago. And this was diagnosed as a bed sore. He was in a nursing home and he had this bed sore. And they couldn't seem to get rid of the bed sore with wound care, oddly. So he came to visit and I did a biopsy and we all know what that was. So it was a squamous cell carcinoma, not a very nice one. So I'm going to digress for a second because you know that he's going to need something beyond surgery, and tell you that patients who develop metastases for squamous cell carcinoma didn't used to have all that good a prognosis, partly because we didn't have good drugs. So they used to get cisplatin-based combination chemotherapy. They all got sick. They were all myelosuppressed. They were all miserable, and then they all recurred. So the next group of agents that we had, and that was about 10 years ago, were the targeted molecular inhibitors, EGFR inhibitors, and that's what I'm going to tell you about with this patient. And then now we're in the immunotherapy checkpoint inhibition era, and that's the most interesting. So we'll talk about that a little as well. So this guy had Mohs, and I got clear margins, and that's his muscle because the tumor went down to his muscle, so it was clearly not a bed sore. And I closed him up, and you see he looks lovely at the time of suture removal, and there's nothing there. And then I like to see patients after suture removal a few weeks later to make sure that everything's healing the way it's supposed to. And there's his in-transit net. So biopsied it, same growth pattern as the tumor, no connection to the epidermis, it's an in-transit net. And so by the time I got him to radiation oncology and medical oncology, he developed axillary mets. So now he's in transit and axillary mets, and we know that he's really not doing well. But now we have this new drug called cetuximab. And so rather than give him cisplatin, because they knew he was going to get sick, he was about 80, they put him on cetuximab, and he did very well. So people who get cetuximab get a rash when it works. They get an acneiform rash. They get horrible, horrible acne. He looked like this all over, but you can see what happened to that in-transit net. And the same thing happened to his axillary net. So basically all of this went away. And 3 years out, he still was free of disease. So this was kind of the first time that I'd seen anything like this, because I'd seen a number of patients die of metastatic disease. Here he is a couple of years later. So clearly no rash, clearly no tumor. It's really remarkable. But the new drugs that we talk about now, because cetuximab only has a success rate of like 18 to 20%, are the PD-1 and PD-L1 inhibitors, which basically enable the immune system to fight off the tumor. So the first of these is pembrolizumab. There are others as well, but this is the one I'm going to tell you about because it was the first drug approved by the FDA for unresectable melanomas. That's relevant to dermatology. We have to talk about it. These are programmed cell death protein inhibitors. The cancer cells basically upregulate PD-L1 on the tumor cells and the tumor infiltrating lymphocytes, and they escape the tumor that way. And so if you block those immune inhibitory pathways using antibodies, then the T cells can work. So then they can fight things off. So here's one of my patients, and he has myelodysplastic syndrome. So he's just a tumor farm. And he had Mohs surgery for this squamous cell on his cheek, which he actually wasn't supposed to have Mohs for because he had a basal cell nearby, but he came in and said, I think this one needs to go today. And he was right. So that's his defect and that's his repair. And so I sent him immediately to my colleagues in radiation oncology and medical oncology. And a year later, he had had radiation. This is his first in-transit met there on the left. He got cetuximab, he got some more radiation, and then he got his next set of in-transit mets. And so then we sent him for the PD-1 inhibitor pembrolizumab, and now he's actually 4 years out. I just saw him a few days ago. And he really doesn't have any of this. He has a lot of new tumors, and they're all sort of flat, but this is really a miracle drug. So pembrolizumab really changed the landscape of management of these patients. But there's a newer drug, and so we always have to go with what's new, and it's cemiplimab. And this is another PD-1 inhibitor, but this one's FDA approved specifically for SCC. So it's been FDA approved for metastatic or locally advanced cSCC which isn't suitable for curative treatment with surgery or radiation. And that happened about 1.5 years ago. It's also an IV drug. And what's happening here? No. So the reason it was approved was based on the Empower trial and a couple of other cohorts, and they were all published together in the New England Journal of Medicine. They pooled all these patients, and it became the largest prospective data set, and advanced cutaneous SCC. So you can look at that for a minute. The neat thing is that, so you have metastatic on the left and locally advanced on the right. And you can see that the confirmed overall response rate for the metastatic group was 45% or 47%, I'm sorry, for the locally advanced was 50%. So that's overall response. So this is unheard of. There were 5% complete responses in the metastatic group and about the same number, 40 to 50% of partial responses in both groups. The median time to response was 2 months. So this is very fast acting, and about 60 to 65% at over 6 months were had durable disease control. So they were still doing well. So this is really revolutionary in terms of the management of these patients. Of course, there are always adverse reactions. The most common ones here were fatigue, rash, and diarrhea, none of which are pleasant, but which most people can get through. There are some serious adverse events as well, and those are more difficult to get through. But the fact was that most people did okay. So these are pictures from the New England Journal paper, pre and post 6 weeks of cemiplimab. So to go from having what looks like a mess all over his head to really having nothing in 6 weeks is extraordinary. And this is another locally advanced tumor behind the ear after 8 weeks. It's not totally gone, but it's pretty much gone. There's still a little ulceration over there, but this is pretty amazing. This is one of those fall plots, and that's the metastatic group. So all the purple ones have a complete or partial response. So you can see just how many of those responded well. And there's actually updated data, which is better than this, but I don't have pictures of it because it's not published yet. But this is tremendous. And that's the progression-free survival curve. So you see it gets to 50%. And so you've got a significant number of patients that are alive with metastatic SCC. It's 50%. Out at there, it's 14, 15 months, and now we've got data beyond that. So this is really the end of my talk. Really, the targeted agents and immune checkpoint inhibitors have changed everything. So as much as we want to get patients early and treat them appropriately and never have them get to the point that I've shown you, we're now able at least to give patients an option that we've never had before. They're mostly well tolerated. There are side effects, but most often they're not treatment limiting. And so these have the potential to revolutionize management of patients who do develop locally advanced or metastatic cSCC. So Monique already told you about the organization. The last few slides here are just showing the cancer centers that the group visited and looked at. Basically, these are multidisciplinary skin cancer programs at GW, Oregon, and also University of Missouri, who are sort of examples that were incorporated into the little book that you have. They're relatively new programs, a couple of them, and so they've really succeeded in multidisciplinary efforts. Those are the references, and that's it. So I'm happy to take questions.